All right. Is it 5 o'clock yet?
It is not.
It's 8 o'clock here.
I guess it depends on where you are, right? Welcome everyone from close here to far away. I'm sure it's a variety of times for everyone, but thanks for taking your time out for this last of the 2019 cycle of Fall Voice webinars. And today for the next hour, we're going to be having a conversation about evaluation and management of the acutely dysphonic singer. We're calling it 24 Hours to Curtain. And I'm Mike Johns from the University of Southern California. I'm a laryngologist there, and I'm going to be doing the moderation. And we've got a terrific group of clinicians who are expert in this area. And let's make some quick introductions. Clark, do you want to say hello?
Yes. Trying to find the hi. I'll find my video button in just 1 second.
You never look better.
Everyone's texting in right now. Mute. Stop video again. Stop video again. Yes. I'm glad to be here. I'm looking forward to learning from everybody.
Clark is director of the UCSF Voice and Swallowing Center at the University of California, San Francisco. We have Juliana Codino and Adam Rubin is our team here on the call tonight. Adam, want to give a quick introduction?
Hi, I'm Adam Rubin. I'm a laryngologist and director of the Lakeshore Professional Voice Center, where I get to team up with the amazing Juliana Codino. Juliana.
Hi, everyone. I'm a speech pathologist specialized in voice, and I've been working with Adam for the last 3 years, and I'm alive.
All right.
Yeah,
lastly, we have Neil Bott with us, and Neil Bott is our outstanding laryngology fellow at the USC Voice Center, and he's going to be fielding questions from the audience. Say hello, Neil.
Hi, how are you all?
And so folks who are listening in, there is a Q&A button that you can type questions in for the panelists, and Neil will take a look at those, and time permitting, we'll try to get those covered throughout the hour. So without further ado, let's get underway. Here are disclosures. Our actual disclosures are listed above. The biggest disclosure that I have here is that I took the title for this 24 Hours to Curtain from Clark Rosen's article from back in 2000. And I went ahead and put here a couple other references, one from Adam Klein and myself on vocal emergencies, and one from Juliana and Adam on the art of caring for the professional singers. Good resources that cover a lot of the topics that we'll be discussing today. I think this is a worthwhile topic because it's something that we face all the time in our clinical practices, yet there's not a lot of evidence that surrounds the decisions that we make. And so we're in this situation where we have fairly acute timelines and within which we need to work, and not a whole lot of evidence with which to work with, along with a whole myriad of other factors that we're going to try to tap into today. And so I think it's a good topic for a conversational approach to managing these situations. As a quick reminder, the Fall Voice Eat, Breathe, Talk community is live. And if you have registered for a Fall Voice conference in the past 2 years, participation in this community is included, and there's a lot of great discussions on a whole wide variety of medical laryngology, speech language pathology topics here. And so please take advantage of this great resource. I've been enjoying the conversation. So this is just a quick overview of the topics we're hoping to cover today. Pathways to care, how acutely ill singers get in touch with us, what we're willing and not willing to do over the telephone, on-site versus in-office evaluation for these patients. We're going to talk a little bit about hard stops for performance, some about acute medical management, what can we really do in this short window of time medically, and what also likewise can we do in this short window of time behaviorally. And lastly, we're going to get into some of the tricky situations that can arise from taking care of touring professionals. So here we go. So this is a case opener. Just nothing that we're going to specifically work through or follow, just a conversation point and to put things in context. This is an actual real situation that I was faced with a little while ago. And there's a 45-year-old woman who's a country western singer, established patient of mine, nearing the end of a pretty busy tour with increasing dysphonia after each show, at least partially responsive to rest, but now has a cold, worsening voice, concern over performance. We've got 5 hours till showtime at the Hollywood Bowl, and I get a text message on my phone seeking urgent evaluation prior to this. So just a little bit of context about the types of situations that we've got to kind of navigate. Which kind of leads to the first question. Clark, let's if you don't mind kicking it off. We're talking about pathways to care. How do these patients get in touch with you? You know, increasingly medicine is getting more complex and corporatized. Oftentimes call centers are layered into our patients' ability to get in touch with us, and it can be challenging. So Clark, how does this typically go down for you, both where you are now and where you've been previously?
Every possible way I've experienced it. I've gotten a call from the ENT resident on call saying, "Hey, I just heard talk to the manager of such and such, and you know such and such is in town, and can you see them?" So I often get a phone call from a local voice teacher who has been contacted by another voice teacher of the specific artist who happens to be in town, and so who was contacted by that manager. So it's like 5 phone calls to get to me, you know, via voice teacher to manager type of thing. So it seems like it's all over the map. Every once in a while they call the office directly, but it is getting more and more hard to get a hold of everybody in the office and get easy access to the office. So I feel like there's been an increase in kind of the circumnavigation communication realm. Instead of getting the phone call directly, I feel like I'm getting it from 2 or 3 different people.
Yeah. Adam, first you, and then Juliana. Adam, how does it go? You may have a little more of a nimble operation, perhaps, maybe more control of the information flow. Tell us how it kind of happens in St. Clair Shores.
Well, in general, they'll call directly to the office, and again, and if that's a singer I don't know, if it's someone who's new, and any acutely ill singer, we have a policy, will be seen within 24 to 48 hours, depending on the urgency. Of course, if they need to be seen that day, they're going to be seen that day. We'll get them in. So my front desk will contact me, and you know, because typically I'll have a full schedule, but we will fit them in where during that first day or within 48 hours if it's not immediately urgent for that night. And if it's a singer that I've worked with, or a singing teacher, or you know, director, they often will have my cell phone directly or my email, so they'll call me directly, and I will arrange it with the front desk.
Juliana, I get a lot of the reports back from the great speech pathology team that I work with, and oftentimes they're more in touch day to day with what's going on with a lot of our patients. And so a lot of these situations end up sort of flowing through our speech path team. How about you? Tell us about this situation.
I sometimes get an email or a message in the office about a patient saying that, oh, I have a cold and I need to perform tonight. If that's the case, I typically defer to Adam unless they're asking specifically about an exercise or something that they would like to review with me. The problem is when we both go to fall voice, and then the 24 to 48 hours is kind of tricky. But there's always, you know, going back and forth with the patients, either email or if they call the office, we talk to them. But typically, if it's a medical emergency, if they contact me, I defer to him and see if he's not in the office, I can scope them and FaceTime with him if he's in the OR or in France or wherever. We try to communicate as fast as we can.
Clark, how liberal are you in giving out your cell phone?
I am very liberal, to tell you the truth. So if I, you know, if I'm working with a manager or a performer, I usually will give them my cell phone.
Adam, sounds the same with you.
Well, it is, because our front desk is phenomenal and they're well trained, but I want to make sure that there are no issues. Every now and then, if someone's having a bad day, they might not be as helpful on the phone. So I want to make sure they have direct contact. Obviously, you get to know your patients, so you might be a little more selective if there's some you're worried about abusing the privilege or something like that. But in general, I want to be as accessible as possible. So they'll have my cell phone and email.
Yeah, I've gotten considerably more liberal about this than, say, I was 15 years ago. The information is universally accessible, particularly the emails, and I'm always amazed how people can find my cell phone anyway, and so I tend to do that. At the USC Voice Center, we set up a hotline. It's kind of a hotline, 844-344-SING, which we've tried to get set up as a dedicated pathway for these folks, and it's real, to be perfectly honest, it's not been particularly successful because that goes straight to our call center pod. If it's after hours, it goes to to on-call doc situation. So it's not been particularly successful. And we've tried to educate our call center team to recognize when there's an acutely ill singer, we need to get the information to us pretty quickly with varying success. I've honestly found the cell phone to be really the easiest way, but it really doesn't help our people who are acutely ill seeking subspecialty care that's not easily accessible.
Right. Does your call center answer for your whole ENT department, Mike, or is it?
It's one large call center for Keck Medicine of USC, and then we have a pod for otolaryngology, and then we've got protocols written around each subspecialty discipline.
It's one of the many problems of academic medicine, in no uncertain terms, is this centralized call center. It's horrible. It's a big burden for us.
Yeah. Okay, all right, so let's keep on trucking. So we're talking about what are you willing to do over the telephone? This happens very frequently. Someone's acutely ill, they are calling, requesting some kind of intervention from you, not asking to be seen or really not necessarily wanting to be seen. Adam, give us a situation that you've kind of been in and tell us about what you're willing to do and what you're not willing to do.
Well, you get that not too infrequently, particularly if it's a patient that you know and are familiar with, you'll get that, I'll get that periodically, not too infrequently. And what I'm willing to do is listen to the history. And while you're listening to the history, like anything, listen to the voice. I actually might have them glissando for me, softly on an and see what they sound like as they're going up, listen to the passaggio, just like I would in the office, to see if there's a new break or something like that, to get a sense of how much vibratory impairment there is. But that said, I typically am pretty conservative in terms of giving out if I'm thinking about steroids or something like that. If they got to perform that night, I will, or soon thereafter, I will typically encourage them to come in. Most of the time they will do that. Most of the time, they're smart enough to realize that if I just give them something, there could be a reason that they shouldn't be going on stage, which we'll talk about obviously later. But I have on occasion someone I know, someone that I counsel that I can't guarantee it's safe for them to perform. I have on occasion given steroids and perhaps some other recommendations for an upper respiratory infection when it sounds like that's the issue.
How about antibiotics?
It all depends on the history and what they sound, how long it's been going on, what's been going on. I try not to be too overzealous with the antibiotics, except for possibly the placebo Z-Pak here and there,
Yeah. Clark.
I mean, this is a super great question, and I really struggle with it. The easier ones are the ones like Adam referenced. If you know them and you have an established patient record with them, they trust you and they're more likely to come in. The more difficult ones are the ones who call you from a phone of a friend and you took care of somebody else in the cast went to you, and now went to you, and now somebody else in the cast is calling you and saying, can you send me some steroids? Can you send me some antibiotics? And those are ones I really struggle with. I generally say no. I have very rarely called in an antibiotic for somebody who I've never met, but was taking care of kind of the whole cast. I've done that once and I've regretted it because I just felt like it was wrong and I kind of was slightly duped into it. But in general, I won't send anybody a prescription for anything unless I've met them and have seen them relatively recently, probably 3-6 months or so.
And
how about you, Michael?
So, you know, I really don't like prescribing steroids or antibiotics or any prescription therapy over the phone. But like you guys, I find myself in those situations where you've got a patient relationship, you know their history, you've seen them a few times, and if they're in a situation that they know they've been in before that's been steroid responsive, I have found myself calling in steroids. I tend to be more judicious in terms of dosing and having a long-term follow-up plan, insisting on a long-term follow-up plan. But admittedly, I have done this, don't like to do it. Antibiotics, I find that there is just less indication for it. Most of folks who are calling us up have acute phonotraumatic edema, or they have upper respiratory tract infection that's typical of a viral illness. And so I find I don't prescribe antibiotics as much, and when it typically is a Z-Pack, like Adam said.
You know where it gets tricky. Where it gets tricky is when you have, you know, one of your singers or a singer that you've met who are touring, and then they may be in the middle of nowhere and they call you and tell you what's going on, and there may or may not be someone they can see there. They got to get on stage. I mean, that's where I think it's really tricky. We're going to see, you know, you're going to be more likely maybe to help them out with a little steroid if they absolutely can't get in to see someone, but try to find someone in the next town that they're going to, you know, they're going to be at that can take a look at them.
Yeah, I mean, I'll tell you, if you want, I'll tell you where I made a recent big mistake I feel guilty of. I got a call on a Saturday afternoon. I was out of town. I was 2 or 3 hours out of town from a performer in a show in town that I had never seen before. I had taken care of a bunch of the cast members, and they wanted antibiotics. And there was nobody in town that could see her. She was, you know, curtain was at 8. This was 3 o'clock in the afternoon. And I unwittingly agreed to call her in a prescription for a Z-Pack. And I'd never seen her before. It was a big mistake. And of course, she promised to come see me Monday, and I followed up with her. She never came back to see me. And I realized that was really a lapse in judgment on my part. And I think I say it because it's a learned lesson for me that, you know, to be cautious about that. And, you know, and it really doesn't surprise me that she never came in because, you know, all too often these people, they're in an urgent situation, and they're going to say and do anything to get what they want. They've sometimes kind of been trained that way, and sometimes they're not so good at follow through and knowing what's good for their overall long-term health. And so that was an error on my part.
All right, let's talk about this. Can be a potentially kind of exciting or hot topic: on-site versus in-office evaluation. So going back to this real but generalizable case study in the beginning, 5 hours, 6 hours to performance time, patient wants an evaluation. What do you typically do, Adam? You've got this window of time. You feel they need to be seen. They need to have some sort of in-person interaction. What do you typically do in that situation?
I try to get them to the office. I think it's a much more effective and thorough way. You have stroboscopy there. I've come in on Saturdays when I've gotten calls and just opened up the office myself and gone in and taken a look. I haven't done a lot of on-site evaluation. You know, so I'll get them in the office and, you know, take a good history and get a good examination and make the best recommendations I can. And obviously I do this with Juliana. We do a tag team approach and or a team approach, and she actually I'll let her speak because I usually, after we're done with the video stroboscopy, I will often hand them off to her to do a little more evaluation and treatment.
Yes, well, if this is a touring performer, we know we're just going to get that one day probably, or maybe one other visit. So in that evaluation, we also have to provide them with the exercises or whatever, whatever we think they need. So we try to prioritize and get everything done within the same visit. I usually just take recordings just to establish that baseline, and then if we get a chance to advance in that session, maybe do post-exercise recordings to see if we're gaining any improvement with the approach we're doing. And then obviously review whatever needs to be reviewed in their performance if they're 5 hours away from the performance. But I think we're going to talk about that later. But obviously SOVTs, if we're working with something that we need to reduce edema, or I love cup phonation for that acute period of time if we have just a short amount of hours before the performance. And yeah, that's about it.
Clark, what office, and obviously we prefer to see our patients where we've got all our high-end equipment. What do you think about the on-site evaluation? Do you do it?
I've only done it once. It was a complete disaster. The performer refused to come to the office because she had hair and makeup and this and that. So I came to her hotel room, which was just across the venue, and it was a disaster. Everything potentially went wrong. My view was bad. I had a hard time finding power for the light source and the scope and you name it. And it was just very suboptimal. So I kind of vowed after that never to do it again. And, if they're calling you for a real serious issue, they'll make their way there. Or you can try to find an otolaryngologist closer to the performer or the performer venue if you're in a really, really big spread out city like Los Angeles, where getting across town in the afternoon is hard. But I think it's in general a bad idea for a variety of reasons that you've already mentioned. Our personnel, our equipment, everything we need to do our job is in our office. And I think that we're not providing the best service when we do, off-site evaluation in the majority of the situations.
Adam, have you ever gone on site?
I haven't had to. Honestly, I've been asked to, but I've always had them come to the office. I think it gets, it's kind of exciting to go on site, with the thought, particularly with those, you're probably dealing with a very big name performer at that point, but, ultimately you have to think about what's better for them. And although, listen, with a good ear and a good flexible examination, or maybe even a mirror examination, but you can bring a fiber optic scope, you could probably make a lot of diagnoses and at least make sure be pretty sure it's safe for them to perform. But I still think, the better part of valor is to have them in the office. I just think you're going to get a much better examination evaluation that way.
And that's kind of what we're getting at, really. The crux of the decision, the most important decision, is it safe to perform or is it not safe to perform? And I will go on site. It doesn't happen very often. It's happened one time since I've been here in Los Angeles in the past few years. And it would happen occasionally when I was at Emory before that. Now, the issue that I have, there's a couple things that I think are relevant to this. One, we're oftentimes getting called by management and they're saying, we have this performer whom we may not have an established relationship with. And my thought around that is, if I say, no, I'm not going to come to you, and sometimes I just can't, but if I say, no, I'm not going to come to you, they're going to find somebody. And somebody may or may not have the right ability, expertise, or diagnostic equipment to really make the accurate call of whether it's really safe for the singer to perform. And when I started out doing this, it was all, like Clark said, it was a total dog and pony show. I tried to bring either a flex scope or a rigid telescope without stroboscopy, but with light illumination. I've done a mirror exam before, and I found it all suboptimal. So, so here, when I came here to USC, we were able to get a telepack, and I find that the stroboscopic images that we can get from the telepack with a rigid transoral endoscope or the distal chip flex endoscope, we've got both, and it all is in a little package. We bring it. I will bring that wheelie because I do think that if you're going to go on site to evaluate these patients, you need to bring a reasonable facsimile of what's going to happen in the office. And I believe that when I bring this there, I'm getting close enough to certainly can see hemorrhages, like I could see most mucosal tears or really significant issues that would help me make the decision. And if it weren't for my thought that, if I'm not going to come with this equipment, they're going to find someone who's probably is not going to be able to bring that kind of evaluation to bear. So it's a challenge. We do get them ultimately set up in our electronic medical record as an established visit at USC, and so we don't do it outside of the existing kind of infrastructure, but it's a challenge. I know this happens a reasonable amount. And Clark, Rosen, before we move on to our next topic, are there people in your communities or wherever you've been who do this on a routine basis?
Not that I know of. I would like to point out it's good to wear gloves when you examine the patients, like the photo in the back. And then also, here's the history question for our viewers. Who knows the name of the headlight that the person in the middle of the exam is wearing? Adam, do you know?
I don't.
Yeah.
Well,
have you ever seen that headlight before? It's old history. It's really cool.
So I think the take-home message here is really press for an in-office evaluation. I think the end of the day, it's the most appropriate, most professional, and safest thing to do. And my message, if people are going on site to evaluate performers, at least have reasonable resolution laryngeal endoscopic equipment to be able to look at your patients appropriately and not shortchange them.
Mike,
Michael,
go ahead, Clark. I'm sorry.
So here's where I think the elephant in the room is, and I think it's a great time to talk about it. We as a field, physicians and speech language pathologists who take care of people with voice disorders, can't compromise our ethical obligation to practice medicine because of somebody with a name and a reputation or money and fame. And I think that we start going down that slippery slope. It's to open the door when you start compromising the quality of your visualization and the quality of what you can do to take care of the patient by going and seeing them in their hotel room or going and seeing them backstage. Now, if you have access to what you were just talking about, that technology, Michael, that's awesome. But I think that I hear about this all the time where, oh, Dr. Such and Such came and saw me. He pulled a mirror out of his coat pocket and said, you need a steroid injection. And out of my other coat pocket, I gave him a steroid injection or a B12 shot or something like that. And I just think that we have to be very careful about the quality of our care, of our specialty, and the ethics of this, because this is where it starts to get pretty dirty and murky, in my opinion.
Mike, do you bring someone with you when you go, or do you go by yourself?
I typically do. I try to have one of the speech pathology team members come with me, both just to help with decision making, right? And these are shared decisions they oftentimes have kind of a better understanding about what the patient's capabilities are going to be from their discussions with them. So it's very useful in deciding whether the show should go on or not. And the second reason is just a chaperone, right?
You want to protect
Totally.
Just like we do in the medical environment.
Michael, would you ever bring steroids with you?
I have in the past. I've brought. I do. We'll typically bring the same mixture of steroids that I use acutely in the office.
Have you ever looked into the infrastructure to do that? Like, are we licensed to treat patients outside of our practice site? As just an example, I don't know the answer to that.
Yeah, it hasn't. It's a good question. I haven't thought that deeply about it for an intramuscular injection. And
it's interesting, actually. I wonder if your malpractice would be if that would be incorporated in that, if you had some reaction or something. Not that it's likely to happen. I wonder.
Yeah, I don't know.
All right, but the core of kind of what we're getting at is is looking at the vocal folds prior to assess our dysphonic patients prior to clearing them for performance or trying to make decisions about getting them through a performance. So what are your hard stops for performance? Clark. Juliana, I've got for you on this one too, okay? Clark.
I think there's two big categories of hard stops. One obviously is hemorrhage. Evidence of it, a hemorrhage that has occurred recently, is kind of the big category. And then, the other hard stop for me is, which I think is the hardest of all of this topic, and that is determining if the performer will be able to complete the task of the evening or of the determination. So I feel like our job is like a flight surgeon. We have to determine if it's safe for that singer to perform that night. So, are they going to hemorrhage? Have they already hemorrhaged? Are they going to, are they so darn swollen that they're going to run a risk of hemorrhaging? So is it safe to perform? The second hard stop or component of that is, are they able to do the performance? Or are they going to lose their voice, before intermission or halfway through the show, and then it looks really bad for everybody? Those are my two big concerns or issues when I'm looking at making that decision, go or no go.
Adam?
Well, he brings up great points. Hemorrhage, mucosal tear are fairly hard stops. And then there's a lot of gray zone in there where you have to weigh a number of factors. And Clark brought up a great point of not only, first of all, the biggest thing, can they perform without putting themselves at risk for a career-threatening injury like deep scar, right? And that's why you think about Harvard and hemorrhage, and don't think about Harvard. You think about hemorrhage and scar. But then there are all those, kind of in between, where they're pretty swollen, they, sick, and you have to weigh a lot of things. You have to weigh, like Clark alluded to, not only can they perform their task, but can they perform it well? You start weighing, what's the risk of performing badly, maybe getting a bad review, or looking unreliable if they're too ready to pull themselves off stage without a real hard stop, for that. And then, there are a whole bunch of other things we could talk about, what kind of performance is it? What kind of music? What genre? Do they have amplification? Are they doing a one song cameo, or do they have 9 of the songs in the musical that they're performing? So in terms of hard stops, I would say, hemorrhage, mucosal tear, and then there's a lot of gray zone in between where it really comes in the art of what we do, and there's a lot of things to consider.
And that's my question for Juliana. So we've got hemorrhage, we've got mucosal tear. The dumb doctors can look and see and make that decision. But this challenging one is, can the performer get through what they need to do acceptably to them? How do you get to that answer?
Yeah, so it's hard, and the gray cases are the hardest. In my experience, there's always like a margin of improvement that we can get that can decrease the vocal fatigue and increase the quality of the voice without causing harm. And that's what we do when we meet with them in that acute period of time. Just go over and tell me exactly which is identified the most demanding piece of the performance, and let's see if we can go through that piece again, and maybe, well, obviously if allowed, you know, change the melodic line, harmonies, and play around with that. If allowed, change the order of the set, or even delegate to the backup singers if there are any there, to try to reduce all the effort on that acutely ill performer. Obviously, as I said at the beginning, see if there's any way. I'm a believer that there's always a healthy way to do almost anything. The problem is if that gray area is more closer to the hard stop, or there's more things that we can do with a few hours notice with that patient before the performance.
Well, you know, I think you make a really important point here, highlighting the value of having someone with your expertise working with these performers, because one, you've got more time to spend with them to navigate these things. You've got the expertise to do it. My approach for navigating that gray zone, you know, starts with, do you think that you can do it acceptably? Do you think you're gonna be able to get through it and be happy with how it went? And I think there's nothing wrong with that. I'm not critiquing, I saw Clark nodding his head. I'm not critiquing myself or that approach, but oftentimes patients probably don't fully know, or at least would benefit from having an independent sounding board reflect on some of these modifications that may take them from an I don't know to a yes or a no.
Mike?
Yeah, so Michael, I think these are very nuanced. This is a very nuanced question about especially the second component of it. You know, are they able to make the performance? And one of the things that I've learned over the years is the difference between a young, brand new singer who hasn't done the role or hasn't been doing this for very long, telling me, yes, I can make it through this, versus the experienced, seasoned singer who's done this a million times, can do it in their sleep, you know, backwards in a different language. You know, when I ask that question, do you think you can put a good show on? Do you think you can sexually make it through the entire show? And then to the experienced singer, and they say, yes, I feel much better, versus the novice, because the novice doesn't know yet, hasn't been through this, hasn't sung sick, hasn't learned how to throttle back, you know, change the repertoire. And so I'm much more comfortable when the experienced singer says, yes, they can do it, than when the novice does. I'm usually more conservative, and I'm much more willing to pull out my hard stop, you know, or, you know, put down my foot and say, hey, this may not be your night. If it's a younger performer that, you know, doesn't have the wear and tear and the chops and the experience to know what they can and can't do, and they're completely motivated by, you know, by living for the short term and not for the long term, or by, you know, pleasing everybody around them, especially their management team.
So I'll add to that. So, you know, you are a sounding board, right, in these gray zones. And there are a lot of other things, even though the number one factor is the safety of the performer, there's no question, you do have to at least discuss other things. What happens if they don't perform? Is the show closed? Is there an understudy? You know, is there anything they can do to modify the performance? We've alluded to that. Is there anything you can do as a physician to help them on stage, which often is, you know, is steroids? What are the short-term versus long-term goals? I mean, is this a performance, they do it, they're getting a huge windfall that might set them up for a long time? Or are they thinking, you know, it's not, this is nothing. I need, you know, long career. I mean, that's what I'm going for. So there are a lot of things that you have to discuss. And although the number one thing is safety of the performer, you have to at least consider these other things when you're talking to them. And again, there are times I know performers. One of my friends is a very well-known Broadway actress who had a hemorrhage, got cast in a very big revival by the composer, and a hemorrhage. She ended up getting kicked out of the show because she felt she was too unreliable. You have to take those things. The demands on these performers, whether it's the successful musical theater performer doing 8 shows a week, or the rock performers who have to do more performances because of Spotify and all that kind of stuff, taking away record sales. The demands are so insane, even in the best trained voices, that you have to try to help to keep these people on stage whenever possible.
Well, Adam reminded me of a great story that was a case that was presented a long time ago by a Brazilian otolaryngologist who presented this strobe of this acutely ill performer, comes in the night before the show, and there's a big hemorrhage in the vocal fold, and everybody in the room says, absolutely, and he asks the room, sing, no sing? Everybody says, absolutely no sing. And then he went on to say how the performer, that's exactly what he told to the performer, but it was the equivalent to, the Brazilian version of American Idol, and that was her finals. And this young performer said, I'm going to go do this no matter what. I don't care what you say. This is my night. This is my one chance to do it. And, she went and did it, and she survived and did okay, and, the whole thing. And, one hemorrhage is not the end of the world. Lucian Salika showed some nice data about that. But so we do have to put everything into context. Obviously, if it's one show and they've got 8 more in the next 8 days, it's not going to work. But if it's one show and you got to make it through, and there's no backup, and this is their one break, it all gets factored in.
I always wonder how we still need more evidence around what happens with vocal fold hemorrhage in terms of long-term consequences. How many times do you think people are out there performing with vocal fold hemorrhages without any knowledge or evaluation? I'm sure it happens all the time and probably without a lot of consequences, but we just don't know.
It's like anything else in medicine and in life. You can get away with things a lot, but you just counsel them that it puts them at risk, right? It's not an absolute. It's not like you sing on that hemorrhage and you're done. It's you sing on a hemorrhage, you might have a problem, afterwards, and it could be a very severe problem,
Yeah, I agree with you, Michael. It's the repeated hemorrhage that worries me the most. The repeated unidentified hemorrhage.
Yeah. All right, just for fun, we'll look at a few quick examples. So we've got 24 hours here to showtime approximately, and we'll make some decisions here on laryngoscopy alone. Can you see that?
Yeah, it's going in kind of weird breakup mode, but you sent us them, so I looked at them, before.
There's two vocal folds, right?
There are 2 vocal folds.
What's the thing sticking up? No, just kidding. You want us to just jump in and comment, or?
Yeah, I can't pause. It doesn't appear, unfortunately. I was hoping I could.
Yeah, it's fine. It's fine.
Let me get a nice image here. I see. This is a patient of mine who was in the middle of a show, was having worsening dysphonia, bilateral vocal fold edema, mid-membranous fullness. And the reason why I included this is you see this epithelial change here on the left vocal fold in the mid-membranous region. It looks like there's some disruption of epithelium, or at least acute changes here.
And there's a little punctate hemorrhage there too, Mike, just anterior to that, right?
Yeah. Clark, is this a potential hard stop on the exam alone?
I don't think so. I'd love to know. I'd love to know what the performance is, and also what her baseline is. But I would say this is not a hard stop for me.
Juliana?
I would definitely listen to their voices more, see what's going on throughout the whole range, see where they have to sing, and try to find a nice sweet spot.
Adam, since this is you,
right before my performance at the Hollywood Bowl, I remember this one.
Yeah, did you What do you think? Would you?
Well,
would
you know, this is a tough one. And
yourself on this?
what'd you say?
Would you perform yourself with this?
I would probably not. I mean, honestly, I think there's risk in that area. I mean, it almost looks like you have granulate, like a healing ulcer there or something like that. We've never seen it before. You know that right at the end of your strobe, you can't hear I can't hear the sound of, but I know that right at the end, he said glissando low to high, and that's a really important area to explore. And you don't want to do it too loudly, you know, just because that passaggio area, you're going to hear significant vibratory impairment. That's the most sensitive area, right? And I would guess that he's got this person, he or she, I can't hear, is going to have a break there. I think it's I think that's risky. I mean, and particularly depending on what he has to sing. I mean, if he's singing loud rock and roll, he'd probably get through it. Belting, probably get through it. But if he started to sing light and high, they're probably going to struggle, assuming that's an acute injury, which I think it is. I probably would rest this person, maybe only for a few days, give steroids, bring them back and take a look, see if the steroids help that area that you alluded to.
All in the context of the aforementioned variables surrounding criticalness of the performance. All right, number next. Pop singer performing day in and day out, worsening dysphonia. Here we go. We have 24 hours. Clark, what do you think?
This one makes me nervous. You know, there's some a little bit of a blush throughout most of the membranous vocal fold. The vocal fold looks stiff as well, and some increased vascularity in addition to the blush. This one makes me more nervous. I'm much more saying closer to saying no on this one.
Juliana?
Context would be helpful.
I agree. This one is more concerning than the other. And obviously, we talked about everything. We should consider everything around this performance, but definitely makes me think of voice rest. And
Adam?
I agree.
Yeah, so the previous example number one, I cleared that patient for performance. This patient shut down. And now let's look at this one, example number 3. This one we don't get a great view to the end. I'm just going to show you a still at the very end. So this is, to me, is a resolving hemorrhage. There's clearly mid-membranous fullness on the left greater than the right vocal fold, but there's acute hemorrhage here with clearance and hemosiderin-laden mucosa in the central zone. So not immediate hemorrhage, but resolving. Is this a no-go, Adam, or a go?
Well, it's hard to tell. That mid portion is actually pretty concerning, even though there's no blood there. Again, it looks like there are epithelial changes there. I mean, it's hard to tell. Were they pretty impaired vibration-wise, Mike? I mean, because I would think they would be, but I can't say for sure.
Yeah, so reduced mucosal wave, particularly centrally here, but not where the hemorrhage is.
Well, it almost looks like it's, you know, a granulating area. So I mean, there was probably mucosal disruption there. I mean, this is a hard stop for me.
Clark?
I'm pretty close to hard stop on this. Blood in front of both, you know, in anterior and posterior. Again, you know, it'd be helpful to hear the voice and know the context of things. I'm sorry for keep saying that again and again. But I think this is super close to a hard stop.
Yeah, this was a hard stop in the context of the situation. And I think I've got one more. This individual performs multiple shows a day at Disneyland. They are a lead in one of the performances.
Is it Elsa?
People could hear this because I know who's doing this stroboscopy, and it's a great examination. I don't know if the viewers can hear the voice of the stroboscopist, but she really put her through a full task here, which was very helpful.
Yeah, this is a good one. So reduced mucosal wave, edema right greater than left, this erythema, and what I kind of call hot dogging of the vocal fold when this whole free edge looks kind of like the shape of a hot dog.
Well, look at the middle third there too, Mike. It's almost like indented, you know, is that new? Is that old? You know, it's hard to say.
No, the one thing that Michael, if you could stop it at some point in time, the little blush around the vocal process there on both sides does not bother me. And I've never seen anybody discuss this, but if you scope people after a significant performance, almost it's not uncommon to see that right in that area. And I had to learn kind of the hard way that sometimes is just how people, look after, a heavy performance. So that doesn't bother me. I mean, the right's a little bit more than normal, but the little blush that you see in front of the vocal process on the left and even the right doesn't bother me. I think that if you've got a way to get this woman some time in the near future to rest, and she absolutely needed to perform tonight, I would be okay to let her sing.
I just can't tell if it's mucosal tear in the middle or if that's just some stiffness, irregularity there. Mike, was it?
So this was an established patient. This was then a new finding, and this patient we let perform and with appropriate medical management and ultimately did okay.
Right.
Here's the scary scenario that you see this patient for the first time ever. They're only in town one day.
Right.
And they come in saying, I want steroids. Those are the people who worry me the most, because those are performers who basically have been enabled by our industry, for lack of a better word. And they now know that they know what to do, and they can ask for steroids in every little town they go to, and we are not giving them good service and taking the best care of them. Those are the people who worry me the most.
With these patients, I agree with you. I say, here's the acute plan, and you can't have an acute plan without having a chronic plan. And I make sure that is articulated. And if we don't actually have the chronic plan already established, then we build the chronic plan.
It's a great plan. I think our responsibility when we see these patients, not just to treat them acutely, but to prepare them for the rest of their career, right? I mean, we can influence these people, teach them about voice preservation, get them going.
And Mike,
yeah, go ahead.
Oh, sorry, Adam. I'm amped up right now. And Michael, you could use the argument, well, if I don't give them steroids, somebody else in town will give them steroids. I still think that the right thing to do is to not fall into that steroid, that recurrent city cycling vagabond trap. I really think we as a group need to avoid that.
Neil, any questions from the participants?
Yeah, we have a few good questions. One was about the recency of vocal fold hemorrhage. To what degree does that affect your decision making? And do you prescribe steroids for a vocal hemorrhage?
Okay, so let's talk, how much does the hemorrhage need to clear before you get them, before you're comfortable with them performing? Rubin.
That's a good question. Well, trying to answer that question directly, obviously, if you're lucky enough to see them acutely, within a day or 2 or 3 of their, vocal accident where they obviously had a significant change and the fold is just full of blood, that's an easy hard stop. So when it happened, 5-6 weeks ago and there's still blood in the cord, was it recurrent hemorrhage? Was it not? You don't know. It's individual, taking all those things into consideration. I would prefer that it all be gone, to be honest with you, but sometimes, similar to what Clark said, there might be a little bit left posteriorly. If it's not in the meat of the vocal fold, right in the striking zone or the anterior 2/3, I'm a little more liberal with it, but there is a gray zone there. But ideally, you want to see that hemorrhage all gone. And honestly, if you catch them early and put them on rest, it often will resolve. So if you see partial resolution, you might keep them quiet, but for a shorter period of time, or on maybe not completely quiet relative voice rest.
So Clark, what do you do for medical management? We're largely talking about steroids here, and can we all agree? And does anyone use anything else other than steroids to acutely improve the patient situation prior to performance?
I use Juliana.
Yeah.
Yeah. I mean, there's behavioral intervention, there's steaming, hydration, but that's all we got. Voice rest, and more voice rest, or we all know it because we do it, and but it's worthwhile making sure that we're managing all the voice production of the performer up until the curtain rises. So we don't want to forget to talk about that important aspect of things.
And mucolytics at all, so steam, hydration, rest. We'll talk about steroids a little bit more.
Okay.
I would let Juliana jump in for something, medical, some behavioral management and things that can do to help.
Juliana, talk to us about behavioral management, behavioral modification.
Yes. Well, we talked about performance and repertoire modifications. Obviously, make the sound guy your best friend. That's one thing that I like to go over, especially if this is a pop singer or not pop, but not necessarily someone with a classical repertoire that will not have a sound guy there. Make sure they're using the right monitors in ear if possible. Anything that can be done regarding the melodic lines, the saving on group numbers for their solo numbers. And again, if we identify which is the part of the show that it's really demanding and the performer is gonna go on stage with an injury, try to see what we can do to avoid that increased impact stress that night, and then obviously build for the long-term plan to plan for that performance better. I was gone for a while, so I don't know if you were talking about this.
No.
That's exactly, we said all of those things. You were perfect.
Okay.
The other thing, Juliana did mention before, things, medically that aren't medicine that can be done, with cup phonation and SOBT.
Oh, yeah. Yes. So when we send someone with an acute hemorrhage, as you were describing a scenario with a cord full of blood, I still have them do some voiceless SOBT exercises during those 3 to 5 days of complete voice rest, and obviously discuss over and over the implications of breaking the protocol and using their voice. So yes, voiceless straw phonation, cup phonation would be the one with a cup and just a little hole. We can increase the diameter of that hole to reduce the resistance. But those are my go-tos. If it's not a horrible hemorrhage, I like to do some resonant voice stuff too with a singer. Mike,
can I just, a couple things for the musical theater performer, knowing from experience is, the rehearsals, they need to learn to mark at rehearsals. And a lot of times the music directors want them going full out, and they really need to learn to protect themselves. And then there also is a tendency for stage performers to because they want energy to give 250%, when really the secret when you're doing 8 shows a week and you're going to do that for months on end is to learn how little you can do to still have an effective performance. And often when they're pushing too much, not only will they hurt themselves, but it ends up being a less effective performance because they kind of break that fourth wall.
Yeah.
Well, we've got 2 minutes left here. Clark, do you want to just talk a little bit about the communication traps and the issues with management that we sometimes face?
Yeah, it's super, super interesting and super important to discuss this. And all too often, especially for the traveling performer, we will often have a more lasting long-term relationship with the management than we do the actual performer. And so we have to be super careful about, making sure that we never violate the patient physician bond and kind of close that loop. So, I never let anybody in the exam room other than the performer without and without making sure that the performer knows that they have the right to have nobody in there other than me. And then when I'm talking about my findings, I only talk to the performer first and foremost. They then can give me permission, preferably written, to talk to anybody else from management and things like that. And if the performer agrees to allow me to talk to management, my preferred technique is to have a three-way conversation. I've made the mistake of saying, why don't you go back and tell the management what we talked about and what we found, and then it becomes all twisted. And then you get the call from management and say, did you really say that they could have 14 days off and I have to pay for them or something crazy? So that's why I learned to A, don't say anything other than to your patient. That's who you have ultimate responsibility to. B, if they do want to include management, if there's any way to have a three-way conversation, either in person, but more often, but in, the two of you in the exam room with the phone connection or a FaceTime connection, and that way you're all on the same page. I've been burned by performers going back and twisting my words or not understanding what I was saying. And so those are the most common traps. The other trap that you have to be really careful of is making sure you don't talk about other performers that you've seen from the same cast, because they'll always have they're always looking for some type of edge, or they're just being nebby, like, oh, I heard that Sabrina was in the other day and she said that you got her all better and she can sing right away, or always digging for information. So that's the 30-second, 60-second version of communication traps taking care of sick singers.
I just had one quick thing is that, you want to talk to the producer or manager in relation to that gig and stuff, but some of that, it's a balance. You don't want to give out too much information, particularly if the patient has a, significant injury that might affect long-term.
And sometimes
I always, go ahead, Juliana, go ahead.
Thing, yeah. When we're talking about performance modifications, managers can be tricky. They're very good in the laryngologist office, and when they come into your session, no, he needs to do that, or oh, that's absolutely the trademark move. We can't change it. So it's tricky both ways.
Yep.
So as usual, the hour goes quickly, and that is our time. I want to highlight the Fall Voice Conference, which is coming up here, and it's looking great. Ted Mao, Galen Garrett, and Robin Samlin have done a really nice job putting a great program together. I'm excited for it. I want to thank Clark, Adam, and Juliana for taking your time out to join us today. Looks like everyone needs to go home except for Adam, who needs to get on the treadmill behind you.
Yeah, I'm debating.
And I want to thank everyone for tuning in and listening. Neil for fielding the questions. What we'll do with the additional questions is stay tuned to the Fall Voice Eat, Breathe, Talk community. We've been posting the webinars to allow some ongoing discussion and questions, and we'll see if we can't get any additional questions from the audience up there on the community discussion board. So
great idea.
Sign off. Have a good evening, morning, or whatever time it is where you are. Thank you so much.
Bye.
Thank you.
Thanks, Mike.